Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
Welcome to TopMedTalk. We are here in Chicago at the Society of Cardiovascular Anesthesiologists 41st Annual Meeting. I'm Desiree Chappell, host and managing editor of TopMedTalk, and I'm joined by Sol Aronson, who is my co-host and past president of the Society of Cardiovascular Anesthesiologists.
Well, thank you, Desiree. What a pleasure to be here with you.
It is. It's fun, isn't
Yes.
it? I love it.
And
so we have a special guest, a friend of yours. So go ahead and introduce our guest,
Dr.
Sol.
Charlie Brown, and I cannot even imagine you've never gotten the next joke that goes with that. But this is Dr. Charles Brown from Johns Hopkins. Not the other character that we're more familiar with.
That's right.
Who I found in the hallways and asked to come join us because I was privileged to hear him be one of the speakers in the Delirium session yesterday here at the ASA. And it was, I'll just go out on a limb and say, I think the best session I've heard of the entire conference. Please introduce yourself to us and let us hear where you're from and what you do.
I go by Charlie. I am Charles Brown IV, so we come from a long line of us. I was the first one named with full knowledge of what would happen. So nevertheless, so I'm associate professor at Johns Hopkins, mostly a cardiac anesthesiologist, and I've really focused my clinical research career around perioperative optimization for older adults, and specifically prevention of delirium and subsequent cognitive and functional decline. And really focused on cardiac surgery as well as other high-risk surgeries such as spine surgery and hip fracture.
And how long have you been in the delirium, if you will, investigation or clinical space?
Yeah, I'd say probably 8 or 9 years. As a fellow, I got interested in this space with my mentor, Chuck Hogue, at the time, and have since really been supported by a sort of welcoming group of geriatric-focused researchers. And a lot of my funding has been through the National Institute of Aging. And I really feel that the geriatric group has been interested in sort of looking at the whole perioperative picture and focusing on really important outcomes like delirium, cognitive decline, functional decline, that no one specialty might own, but are really important patient-centered outcomes.
And Charlie, just for setting foundation, define delirium and define how that might be different than cognitive dysfunction or dementia or some of the other terms that we use to capture this domain.
Sure, yeah. So there's a couple key criteria that we think about with delirium. So first of all is there is a change in a patient's mental status that is, we say, acute and fluctuating. It changes throughout the course of a day, and it's different from baseline. So someone who's demented may have change in cognitive status, but that has been constant and declining over time. Delirium is really an acute change, and we often see it in the postoperative period. And then we look at a couple other criteria. So we want to see someone who has the inability to be attentive. And by that is, when there's something in front of you, can you really concentrate on that? And then a change in thinking or a change in consciousness. And those are some of the key criteria for delirium. So it's really in the postoperative period, it's a change from baseline and a lack of attention and thinking. Cognitive decline, we think of more as in the days, months, weeks, and years after the surgery, and delirium may be related to cognitive decline. So there are several studies suggesting that patients who have delirium in the postoperative period have worse cognitive outcomes at 1 to 3 months, with then recovery out to a year afterwards. And it's really unclear if delirium is a stress test for the brain, where someone who has delirium is vulnerable, or whether there are things that are going on in the peri-procedural period that can lead to further cognitive decline. That's an active area of research.
Excellent. The prevalence of delirium, I'm sure, is dependent on the population that you measure it in. Give us some sense of what we're looking at in terms of the problem and the scope.
Yeah, so the first point to make is that it's one of these conditions that the prevalence really depends on how you measure it. And that could be the tool that you're using or how you even operationalize it. That being said, if you look across the studies, I would say that cardiac surgery is in the highest, hip fracture surgery as well, and then bigger surgeries are also high. Within the cardiac surgery population, the incidences have been sort of in the 30 to 40% range for incident delirium after cardiac surgery. I'd say hip fractures around that as well. Mm-hmm. And then other big surgeries are probably more in the 15 to 25% range.
Wow, that's huge.
And it's a disease, I'm guessing, by the nature of those procedures that is more prevalent in the elderly than not.
Yep. So there are key risk factors that we think of for who is going to get delirium, what patient vulnerabilities there are. And some of those are age is a key one. Baseline cognitive impairment is another key one. There are other factors that are associated with it. And then what kind of surgical stress have you had? What kind of things have happened in the perioperative period? What kind of drugs have you gotten? Have you gotten infections? Have you had a prolonged ICU stay? So there's some balance between patient vulnerabilities and what happens in the peri-procedural area.
And why do we care?
Yeah.
So for several reasons. So first of all, delirium in the postoperative period is distressing for patients and for family members when they see their loved one experiencing symptoms of hallucinations, not thinking clearly, or even apathy, not engaging in their care.
That's what I was going to say. I think that sometimes that's even scarier that, mom who's normally so, upbeat and excited about life is just there sitting there. That's very scary. And you don't know what that is at all.
Very scary.
Yeah.
And secondly, there's associations with short-term outcomes like length of stay in the hospital, need for sitter, discharge location, not going back to home, and cost. Then there's longer-term associations. So we talked a little bit about potential cognitive implications, associations with functional decline. And we're not quite sure, is this a causative relationship or a marker, but that's an active area of research. Because one hypothesis is that preventing things that cause delirium may prevent some of these longer-term complications. And that's a reason that it's important. So it's prevalent, it's common, and is associated with longer-term complications, and so it may be a modifiable target.
Charlie, one of the things that really struck me when you were giving your presentation yesterday is you also mentioned a lot of other collateral, if you will. I don't know if it's fair to say predictors, but associated factors that are commonly found in the patient who would be susceptible to this outcome. Things like preoperative nutrition status, things like preoperative fitness, things like what we call frailty. Speak to us a little bit about that, and I'll lead you to understand what my follow-up will be, is how can we bend the curve? What do you anticipate would be the next step for us to be proactive in bending that curve?
So I think some of the key risk factors are going to be age, baseline cognition, and then in the cardiovascular surgery population, it really seems like cerebrovascular disease has become a key risk factor. And that's slightly different from the medical and non-cardiac surgical population, where clearly age and cognitive impairment are also important. But we also see functional status, kind of illness severity, frailty, as you mentioned, being also key risk factors. The challenge is there's been a lot of work and a lot of studies on identifying risk factors. But which of the exposures and insults, which things are modifiable? And that gets to your point of how do we bend the curve? Yeah. And so there's basic and clinical work looking at isolated factors, so cerebrovascular contributions, neuroinflammatory hypotheses. And they will probably do a lot to elucidate pathophysiology. And that will help with targeted interventions. And so I alluded in the talk about the role of dexmedetomidine and how there are sort of biological reasons why dexmedetomidine may help with longer-term cognitive changes and preventing those. So the basic research and translational research will really help in that. In parallel, there's sort of a movement of trying to take non-pharmacologic approaches, which as a bundle have been shown to be effective, and really get them into the hospital setting in terms of implementation. And some of those things are easy to say and hard to do, right? Yeah, so are you mobilizing the patient early? Are you allowing family to be present to reorient the patient and have a comfortable environment? Are you helping with the sleep-wake cycle? Are you giving patients back their hearing aids and glasses? These are all very powerful and have been shown in a lot of big studies to be effective, but they're hard to do and they're hard to implement. And so in parallel with the basic and clinical translational research, a lot of societies have put out guidelines saying these are things that we expect you to do and we're going to start to measure you on.
Yeah, that's great. I mean, that's so important. We've talked to Lee Fleischer and Carol Peden about the Brain Health Initiative and Miles Berger and, a lot of these different things. And that is always the theme that's coming out of it. The practical reality is this is what we're going to have to do afterwards. And how do we get providers to actually start implementing that? And it's difficult.
One of the other things, I agree, and sort of taking those higher risk patients, it would be a beginning, perhaps. Pulling through is a whole nother implementation strategy and hurdle that we have to learn how to manage better. One of the things that you spoke to yesterday that really got my attention, there were many, one of them was the olfactory sensation as a signal of impending, if you will, likelihood of having this outcome. Speak to us a little bit about that.
Yeah, so we got interested in this because of this notion that sensory impairment has been a risk factor for delirium and cognitive change. And so we conducted a study where we actually measured prospectively patients' sense of smell, and we used sort of a validated model that presents smells to people before surgery. And we found that actually an impairment of smell is quite common in the cardiac surgery population. It increases with age and is almost 33% in our study. And afterwards, those patients who had impaired olfaction and reduced sense of smell had an almost twofold incidence increase in delirium. And it wouldn't be necessarily intuitively obvious. It is known, it's well known that impaired olfaction is an early harbinger of dementia, actually.
Really?
And so there is a potential sense that, it is a marker of undiagnosed neurodegenerative disease that we just don't see. Yeah. So it could be a marker of susceptibility. It could be a marker of a disconnectivity in various areas of the brain. We don't quite know the pathophysiology, but it fits with a lot of the work showing that sensory impairment and integration of information is a key predictor of delirium. And it fits with a lot of work suggesting that patient vulnerability is really important.
Yeah.
And it may be more important than some of the modifiable risk factors that we look to change in the operating room.
Wow. That's fascinating.
Awesome.
It is.
How does one do an olfactory sensory test?
What do we smell in here?
Yeah,
is it wine?
We have scratch and sniff.
Grape flavor,
cards,
banana, orange.
Careful.
Well, on that note, that's fascinating conversation. I hope we can talk more about this in the coming year. And brain health is really important to us here on TopMed Talk. We've been talking a lot about it.
Great. So, yeah, I think it's a really important area, and thank you for having me on and sort of giving the platform to really talk about this important issue.
Oh, absolutely. Yeah. Thank you so much, Troy.
Our pleasure. Keep up the good work.
Yeah,
Thank you very
absolutely.
much.
You're doing great things.
Thanks.
So hold on one second. We just want to give a shout out to all those that have been listening to TopMed Talk throughout the Society of Cardiovascular Anesthesiology. We also are actually at TopMed Talks at the Royal College of Anaesthetists Anesthesia 2019 meeting in London. So this is our first time we're actually tagging two meetings at the same time.
Going on concomitantly.
It is, and it's fantastic.
Everybody.
Joff Lacey is there, and Monty will be there and coming to you over the next couple days. So be sure to listen. Follow us on social media, Twitter, Facebook, LinkedIn, as well as Instagram. We have pics now. And follow us and subscribe on TopMed Talk. Cheers.
TopMed Talk.
Nick Majerison here. Thanks for listening to TopMed Talk. Now, before we let you go, it's important that we remind you to subscribe to TopMed Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, TopMed Talk is proud to act as the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMed Talk. That's ebpom.org/meetings.